I'd like to welcome Berneta Haynes to, who is our moderator for the last panel. Berneta is a senior attorney at the National Consumer Law Center. In this role, she focuses on consumer energy policy and medical debt. So thank you so much for moderating this panel.
I don't know if this is on. Oh, it's on. Okay. Well, I'm going to sit down, and I have one at my seat, but I want to start here. Hi, everyone. Glad everybody's coming back in for the last session. We're going to try to rock this, go out with a bang here. I would like to introduce the lovely panelists for this session, where we'll be talking about systemic solutions, some of the big, hairy solutions to medical debt, long-term solutions. We have with us G. Bai, who is a professor of accounting at the Johns Hopkins Carey Business School, and she's a professor of health policy and management at Johns Hopkins. Sara Collins from Commonwealth. She is a senior scholar for healthcare coverage and access at the Commonwealth Fund. Dr. Ed Weisbart from St. Louis is a national board secretary of the Physicians for a National Health Program. And last but certainly not least, we have Wes Yin, a professor of economics at the Anderson School of Management and Luskin School of Public Affairs at the University of California. Bless his heart for coming so far away. All right, we'll go ahead and get started. All right, so let's jump on into this. I don't think I need to even preface this by saying that medical debt is really about healthcare affordability, because we've already covered that. So let's get right on into the questions. What are some of the causes that you all see? And I want to kind of popcorn this around. What are the causes and consequences of high prices that we see? And what can be done to address some of those problems? Let's start with Ed, and then we'll sort of popcorn it around.
Why, thank you. So, first of all, let me just say it's sort of my job to put all y'all out of business. You're all, everybody in this room is astonishingly well focused on solutions that are just spectacular. But I'm glad for this afternoon's this session, where we can try to get upstream of that and figure out how y'all can do other stuff instead of the wonderful things we heard about. So one thing that's not the root cause is overutilization. And most of the strategies that we hear from people is that we need to put skin in the game. We need to cut back on utilization. And we're about average on that. But what the root causes are is directly from fragmentation. It's directly from fragmentation. So there's all of this overhead from operating this Byzantine system. There's a lack of an ability to price negotiate because of our fragmentation. And those things drive the vast majority of why we spend double. Most of the other solutions are just focusing on little pieces of it, but it's the fragmentation, the lack of negotiation, and the incredible administrative bureaucracy required for such a fragmented, profit-driven system.
Awesome. And Wes, would you like to offer some insights here too?
Yeah, I mean, can you hear me okay? Yeah, I mean, I like to think about like the medical debt issue at the tail end as the tail end of a healthcare financing pipeline. At the very, very end, you have medical debt. And then you have medical debt solutions such as, the credit reporting side, and you have issues of like medical debt relief. And I think all of that work has shown us like that's important, but we really have to, again, as everyone's echoed, like move upstream. And so obviously I focus on, the importance of coverage, but even in terms of coverage, it's one thing to have coverage, and it's also another issue to have good coverage. And one of the issues that we're seeing now is the increasing shifting of medical expenditure risk onto the consumers. And so why is that happening? We can then further go upstream, which we get to the issue of cost. Okay, so I'm going to quote a really good friend and mentor of mine who's passed, which is Uwe Reinhardt, who 20 years ago said, "It's the price is stupid." When he said that 20 years ago, we had not seen the continued wave of consolidation, the horizontal consolidation. We had not seen the big wave of vertical integration, which has led to things like transfer pricing to related parties and weird things like PBMs restricting generic coverage. We had not seen at that time, when he said that, the big wave of private equity. And so there's a big issue of, when we look at the pricing issues, upstream is pricing and consolidation. So we really have to contend with that in a really fundamental way. And that's that's the issue of, okay, we've already let consolidation happen, okay, and we don't have the statutes that really address the types of consolidations that we're seeing, because those statutes just weren't written in this context for the piecemeal consolidations that are death by 1,000 cuts. We also don't have the ability to then regulate the conduct of things that have already emerged, and so that's a really important thing for us to do, to examine that. The last thing I'll mention is one step further upstream than even that is people's like purchasing power and wages. And so I do think about the healthcare system in terms of the context of a larger sectoral input into the greater economy, and so the supply side efficiencies with the national economy. I'm wearing my OMB chief economist hat now, but we do have to think about like what consolidation is doing and the weakening of labor power in general, and what that means for the ability to purchase something that's also already becoming more expensive. So those are some of the root causes that I see, and happy to talk about solutions.
Yeah, I think I'm already getting a hint of one of the solutions. But before we go right to that next question about solutions, I want to see if Sara or G have any comments on this question.
Sorry, I have it in my hand.
They turn it on for you.
Okay, so the Commonwealth Fund has been tracking both people who are uninsured, obviously, but also people who are underinsured. So we developed a measure a long time ago that we continue to track that looks at the share that people spend out of pocket relative to their income every year, and also the size of their deductibles. And our thresholds are 5%. If your deductible is over 5% of your income, we consider you underinsured. Or if you spent more than 10% of your income on out-of-pocket costs over the past 12 months. Or if you're low income, if your income's under 200% of poverty and you spent more than 5%, we consider you low, underinsured. So in 2024, about a quarter of the country was these are people who are insured all year, but underinsured. And when we ask about medical debt, 44% of people who are underinsured reported medical debt. 35% of people who are uninsured reported medical debt. That is really a reflection of use. People who don't have care, don't use that, to have coverage, don't use that much care. And it points to the real serious issue in our healthcare system, which is our health benefits are not adequate. And I guess on prices, the thing that always gets me, if you think about it, prices. When we ask people about the source of their debt, the majority of debt, people report that hospital, outpatient or inpatient care is their primary source of debt. Prices, as panelists have been saying, are the major driver of healthcare costs in the system, and particularly the prices that hospitals charge. Okay, so those prices drive healthcare costs, which also in turn drive premiums, which in turn drive growth in deductibles and out-of-pocket costs, which in turn drive medical debt to the very institutions that started the problem in the first place. So it is shameful, I think, that hospitals actually go after patients for medical debt without recognizing their role in this problem.
I'll just quickly add, I believe it's purely a pricing issue, right? If we experience the very rapid decline in price as in other markets, think about storage, the cloud storage or iPhone or car, we will not have a medical debt discussion today, right? But then why is price so high? I'm looking at this from two ways. The first one, supply. We are having all sorts of, in my opinion, regulation related barriers for entrance, and also think about 340B, think about the physician in the hospital. Now we have the set-based payment, right? Set-based payment, not set-neutral payment. There are many other examples like certificate of needs law, many such examples. So those barriers really incentivize the providers to consolidate, as I said, consolidate and raise the price. And then on the consumer side, in all other markets, we have very conscious consumers using their own money. So they put the pressure, this two-party payment system put pressure on the pricing, right? If you charge me, I'm going to leave and go to other places. But in healthcare, we kind of have patients insulated in many cases. And that's why on the two-party, when people pay cash, if you look at him and hers, right, the price is extremely efficient, very low, and decline quickly. But on the other hand, right, if we have this convoluted middleman in the middle, and then we are less likely to see price decline. So to me, it's really a pricing issue caused by distorted supply and distorted demand. Thank you.
Thank you. And so we'll move on to the solution part of this question. What's one policy you think is especially important then for bringing down the cost for patients? And I'll start with Wes.
That's a great question. So I think on the antitrust side, I think there's two issues. Like one is about how to prevent continued consolidation. And I think that there's probably a great scope for both federal, and here's where state actions are really important. There's a lot of actions that can be taken on the state side to monitor mergers and acquisitions more aggressively. And I think that that's, again, forward-looking about like the prevention of anti-competitive mergers and acquisitions. There's also quite a bit that can be done on the monitoring of conduct, given that we already have 90% of hospital markets that are already highly concentrated by DOJ standards. So in that case, forward-looking reviews of future mergers really isn't so much the issue now. It's actually the conduct that's already happening, such as all or nothing contracting and cross-market consolidations that have led to extraction of rents from like larger employers, so on and so forth, and some of the other issues that I mentioned earlier about PBMs and related party transfers. I think another direction that we need to think about going, which is, well, let's think about different ways that we can regulate or provide discipline on prices. That could be out-of-network pricing caps, which then alters outside options and bargaining power. That could be on public auctions, which again inserts some sort of discipline in the market. But even then, you can have weak versions of public option and strong versions of public options. It has to have teeth to happen. We have some state innovations that are going on there. Then in the most extreme version, you can regulate prices. And so to me, it doesn't matter so much when we think about like wider coverage. It doesn't matter to me whether it's publicly administered insurance or privately administered insurance. What matters is that we're paying for it and that we're doing something about the pricing. And so those two things have to be done.
That's a great comment, and we'll get back to that question of public versus privately administered insurance as well. Any other responses to this question about solutions to bring the prices down?
I have one.
Ed?
So, the organization that I'm with, we're pretty well focused on the idea of a single-payer national health insurance program modeled on improving Medicare. So it would be first dollar coverage for a comprehensive suite of benefits, all the things that are really medically appropriate. So if you provided that around the country, the reason that's so important to me is that it actually does get at price. Even without tapping into the negotiating power, it gets at price. If a third of what we spend on healthcare today is going into the cost of propping up the administration, then if you can simplify that approach, you've captured most of the savings that we're trying to get through other less aggressive solutions. So we know that the insurance industry has let's call it a 15% SEC reported overhead and profits. And we know that Medicare operates with about a 2% overhead. So that right off is part of it. And we also know that another 15 or 20% of what we spend on healthcare today is really insurance overhead that's hidden and obscured on the delivery side. So it happens that we have about 900,000 hospital beds in the United States. I counted them, and I'm exhausted. We have about 900,000 hospital beds, and hospitals report roughly 900,000 full-time equivalents working in billing and insurance-related functions. Roughly one employee in billing, hospital billing, for every bed. We don't have doctors or nurses like that, but we do have billing staff like that. So one little example of that would be Duke has about 800 hospital beds, more or less, and the University of Toronto has about 800 hospital beds. Duke publicly stated that they have 1,600 billing people, and the University of Toronto has publicly stated that they have 7 billing people. And most of those 7 are to take care of Americans who came across the border. So, I mean, how do you pay for that? I mean, that gets embedded into the fee schedule. That gets embedded into the DRGs. That gets embedded into all of the overhead that then goes into the premiums, that goes into everything else that we were just hearing about. So the last time I saw an estimate from Milliman about physician practices, it was about $100,000 of office staff dealing with the insurance industry. Whereas in Canada, it was about $20,000. Where does that money come from? It comes from fee schedules. So that goes into premiums. And all of that adds up to about 1/3 of what we spend on healthcare is this overt and hidden cost of our Byzantine, fragmented, profit-centric insurance model that would largely disappear under a single-payer Medicare for all system. So that's a big chunk. That's let's say 30% that we could save if we did that. Most of the other solutions you could compete for price on LASIK because you can shop around. I can compete for price on a phone because I know the features I want on my iPhone that are different from the ones my wife wants on her phone. But you can't compete when you're having a heart attack or when you need your cancer care. And I don't see, and that's where most of the money goes into severely sick people, and that's the last person you want to make price shop. So anyway, that's what I think.
They're going to call you a jobs killer if you start framing it that way.
Go ahead and answer that.
No, go right ahead then.
So that's been looked at. If you did do that, there would be about 1 million jobs that would be displaced, more or less. Understand, every year we have 20 million people that are fired, another 20 million people who quit, and another 20 million people who leave the workforce for whatever other reason. So every year we have 60 million, 60 million, 60 million job changing. This would be 61 million, 60, 66. So it's something that and the bills that propose this model talk about income protection and retraining, and then with all this work we'd need to be doing in healthcare. So they would have all the nurses and stuff. They would have stuff to do. And the other functions are largely functions that could transfer into other industries. So, yeah, it would be a little bump, but it would be a bump that oh my God, we have to get over that, and we can't stop adding. It's killing people, and we can't keep that up because it's too deadly.
I said that as a joke because it reminds me of I was an environmental attorney, and every time we talked about transitioning away from coal, it's like, you're going to kill all the jobs. And we always talked about how the bills have to include retraining people for other types of occupations, and also realistically recognizing that some people can't be retrained and so forth. But I could see the same argument happening. G and Sara, I want to make sure you have a chance to answer that question too about what you think might be the one policy solution to bring down the cost.
Thank you. I think we should move healthcare as close as if we're buying a coffee. Think about the COVID-19 at-home test. One government worried about the affordability, so send us free test, right? That costs about $30. But once they open up, see what's the price in Europe is about 1 to 2 euros. So let the patient control their own money and make it as simple as possible. In terms of low income and high risk patients, we should absolutely give them comprehensive insurance and try to directly sponsor them, direct the money channel to them. Imagine you are Medicaid patients. If you have any money controlled in your hand, don't you think you have higher incentive to seek for better health status so you don't get sick, and then cheaper options? Right now, if you're a Medicaid patient, no matter how hard you try, you get no benefit, right? You cannot get any money left in your pocket. So that really reduces the incentive. So therefore, I believe the subsidy should try to not give to the system, but give to patients, and also move other healthcare items, like let's say primary care. We have a paper published in Journal Internal Medicine talking about how we should move primary care to direct pay. So we just pay the money, and then we get the primary care, And in return, we get a lower premium, and that will be used, for us to have more dispensable income. Thank you.
And Sarah.
I might say something a little different than that. But I like that idea. But anyway, so I think healthcare is totally different from other industries. In most industries, costs drive prices. In the healthcare industry, prices drive costs. It is completely backwards. The prices bear very little relationship to costs. So we actually do have to do something about price. I agree on the consolidation issue. I think the train has kind of left the station at this point. So we are going to have to think more about Medicare prices and how are rates set in Medicare, and how can that inform where we might go forward. The Urban Institute did a couple years ago, or now going back to 2019, I guess, when Medicare for All was very prominent in the policy discussion in the 2020 election. Urban did some really nice work showing that you could reach universal coverage by building on the Affordable Care Act. You could also reach universal coverage with the Medicare for All approach. The big difference, unless you did something, was the cost. And Medicare for All achieved much lower costs. So you covered everybody at much lower costs. That was because of the price. And so what Urban did was, let's place a public option, auto enrollment plus public option in the mix of things, so that you build the cloud of a public option, and you have negotiated rates at a percent of Medicare in the public option. So it was possible to get close to universal coverage, or at least near universal coverage, at a price that was close to the Medicare for All. So it really does come down to how much we are reimbursing providers, and we really do have to look. It's hard politically to talk about this. Even states are trying to do this with public options, but it's been difficult, and they've ended up with relatively weak public options. But I think driving the cost down is going to really require us to think hard about what we pay for healthcare and commercial insurance markets.
And that's a great segue into this broader discussion about public versus private insurance, and public structures potentially being a solution. There was a Gallup poll, the latest Gallup poll, I believe was in December of last year, that showed about 62% of Americans believe that it is the federal government's job to ensure that all Americans have health coverage. Now, what that health coverage ends up looking like, the poll did not go into that level of detail. But I'm interested to hear from panelists here what your thoughts are in terms of whether you think a single-payer universal health coverage system would fix the problem of medical debt. And yes or no, what we could learn from other countries and what we could learn from our existing U.S. single-payer systems like the VA system and so forth. And I'll let anyone who wants to jump in first jump in there.
I think it will solve. Imagine tomorrow we have a insurance for our grocery, 100% covered, no out-of-pocket payment. There will be no grocery-related debt at all overnight, right? Yeah, for sure, because it's all covered. And then in return, we increase tax, right? We got the federal revenue, and then we just split, and then people can buy. No medical debt, no debt related to grocery overnight. But then what will come back? Imagine now the grocery stores get the money from the government, right? So what is the incentive for them to provide more variety, or better quality? There's no incentive, because if you leave, as a consumer, you leave the market, go to another grocery store, does not affect the revenue. So that is, I think, the trade-off we have to face.
I think I know somebody who doesn't like to eat, but other than that one person that I can think of, everybody I know wants to eat. They eat as often as they can. I don't know anybody who likes to go get health care. If you took away the financial barriers, there would be some people who would. And indeed, I worked in a setting where, as I practiced in a setting where we didn't have copays for a long time, and there were a few people who came in who probably didn't need to come in. But when you got to know them better, you found out that the reason they came in was there was a whole agenda of psychosocial problems that it took months of them coming in for silly things before they felt comfortable talking about the really fundamental things. And once you got to know them through primary care and got past that, then suddenly their utilization of these services started to go back down. So I don't see anybody waking up in the morning going, should I go golfing or go get a colonoscopy? Which is more fun? You know, I just don't see that we need to do that. And instead, every time you put in financial barriers to care, most patients don't have the resources to adequately distinguish between whether this is life-saving. Is that statin really going to prevent that heart attack? I don't know if I really believe that. You know, they'll adhere to their pain meds, but the other stuff, they will stop complying. We know this. I mean, I used to work at a large pharmacy benefit management company, and we know that if the copays reduce utilization across the board for things that are medically life-saving and things that are not anywhere near as health important. So that's just not the way forward. You know, that's just not, that doesn't get to the root problems that I was talking to.
I have a funny little comment about what you just said. I don't know anyone who likes to go seek health care. I have a friend who has lived in South Korea in Seoul for 20 years now. And he's married there. He's a permanent resident, thinking about getting his citizenship finally. And apparently there's a big screening thing that happens at some point when people hit a certain age for like stomach cancer or something like that. And he's like, my wife, her whole family, all my colleagues are so excited. He's like, they're all like, oh, I can't wait to get my screening. And he's like, I'm looking around like, why do you want to go to the doctor? And I politely told him, you're very American. And it's never going to get, that part of you is never going to leave you because we're permanently traumatized. But anyway, I just think that's a funny story because it's very American to not want to go to the doctor, I think. So, Wes.
Yeah, I want to come back to your question about public or private. And I think like ultimately an important aspect of this is that there's some strong aspect of public subsidies and public support, because as I'm echoing a lot of what I've said earlier, I mean, in some sense, it's not just a free market, there's a distributional aspect of healthcare in our system. We have to recognize that. And in some sense, the way that you build in subsidies oftentimes is distortionary, but we have to be okay with that as a value statement in society. We all have different views on that, but I think we have to just accept that. So an important aspect of public or private is, you know what, it kind of doesn't matter as long as we do have that the financing of it. Now, whether it's administered publicly or not, whether it's a single payer or not, I think it still comes down to like how we administer the prices and what types of, even in a publicly run insurance, we still have to incentivize the providers in some ways. So we always have these incentive issues that we have to deal with, and we can imagine, well, we can get it wrong in either way. We can get it right in either way. So in Medicare pricing, we have a long history of struggling and contend with how do we set those prices correctly. And then we said, you know what, let's have the private market do this. We have competition run. But you know what, like, okay, then we have to worry about the provider incentives and things like that. So we have capitated payments. Then we just overpay Medicare Advantage. So like it's always a struggle, and it's a political process ultimately, given how much the public pays for it. So to me, whether it's a single payer public insurer or a private insurer, it's just a different set of issues that we have to contend with when it comes to the issue of setting prices and price growth. So.
Appreciate that perspective. Yeah. Sara?
So we have an international survey that we run every other year. And we have a question on that survey that it's kind of like medical debt. It's just, you know, do you have problems paying your bills, or you're not able to pay your bills over the last couple of years or so? And the U.S. obviously is highest, about 22%. Some of other survey data, our survey data, national survey, a little bit higher than that. Kaiser's a little bit higher than that. But in any case, for this particular survey, about 22%. This was about 9 percentage points higher than the worst country, Australia. It was 4 percentage points higher than the UK. So that's the rates are obviously quite a lot higher in the United States. And so if you look at internationally and the differences between the U.S. and OECD countries with universal health systems, It's the 22% reflects our uninsured rate, but it also reflects cost sharing. The average deductible in employer-based plans right now, this is the latest 2023 MAPS data, ranges from $1,200 in Hawaii to $2,600 in South Dakota. That's just the average. In 24 states, the average deductible for employer-based plans exceeds our underinsured threshold, so 5% of state median income. So if you look at OECD countries, with the exception of UK and Canada, there is minimal cost sharing. So primary care, there's never cost sharing for primary care, or it's quite minimal. Specialty care, a little bit of cost sharing, maybe in Australia, $56, France, $17 to $26, Netherlands, up to a $468 mandatory deductible. Compare that to the average deductible in employer-based plans. Okay, and then Switzerland is always held up. Often, this is going years ago during discussions before the Affordable Care Act, as a model that conservatives pointed to as potentially one that could fit the United States. And it is true. Switzerland does have higher copays than other universal healthcare systems. 131 to 200. These are 2023. Actually, earlier than that, but anyway, you get the point. $200 visits for physician services. So full cost up to a deductible plus 10% coinsurance. The out-of-pocket max in Switzerland is $2,600. Okay, compare that to the new out-of-pocket max in the administration's marketplace rule for next year. For individuals, $10,600 and $2,100 for a family. So, and then just one more interesting statistic about the Netherlands. So Netherlands, this is Germany. Excuse me. Germany caps their out-of-pocket costs. This is not including premiums. This is just out-of-pocket at 2% of household income and 1% if you have chronic health problem. Compare that to our underinsured measures. Compare that to what people pay even in marketplace plans. So we are obviously so far behind other countries in our rational, in our approach to making sure people have adequate health insurance coverage. And I'll say one more thing, because everyone always says, well, we'll pay more taxes. That is true. However, we also pay a lot in premiums. Yes. And you look at the Affordable Care Act's schedule, you pay up to 8.5% now until the tax credits will probably go away. The enhanced tax credits will probably go away at the end of this year. And then we're back up to a maximum at 9% and a cliff at 400% of poverty. So we are paying a lot in premiums for coverage that is really not very good.
You asked, the question you were asking was about public versus private insurance as a fundamental model, and it's really hard for me to understand what value the commercial insurance industry is adding to this equation and how they can. And I grew up as a zealot fan of the commercial insurance industry. I was a senior executive at a regional health maintenance organization. I got recruited then to go into being the chief medical officer of a large pharmacy benefit manager. And I was excited, right? I thought I can do all kinds of good public good. And so I'll give you one example of where I kind of really went far down into, no, that's not really a good solution. So I went to work there, and I thought, well, one of the first things I would do is put in a campaign to encourage people to adhere to their cholesterol medications. At the time, those were all statins, and I was a believer that statins really prevented heart disease. So let's do a campaign to increase adherence to cholesterol medications. Great, we'll sell more cholesterol medications. We'll make more money. Our clients, the employers, will have fewer heart attacks to deal with, and then they'll be great. So everybody wins. Patients will do. I was really excited. The problem we had was that our clients, in this fragmented world we live in, our clients knew that they had about 20% annual turnover of membership every year. people coming in, people leaving, people changing jobs, employers changing. So the question that they all asked was, okay, you want us to pay for this program to increase adherence to this life-saving cholesterol medication, without even questioning that part of it. You want us to pay for that program. How long will you have to be on this program? How long do you have to take a statin to prevent a heart attack? And I said, about 10 years. They said, great. So you know that 2 or 3 years from now, half of our employees won't work here. So we'll have done this campaign that we spent money on to improve the health of our employees, who by the time the benefit comes in, they'll be working for our competition. Why would we pay you for that? And that was, so the fragmentation of our insurance system, which is key to having a commercial insurance model, the fragmentation is corrosive to public health. It's not just neutral to it, it corrodes public health. It undermines any long-term public health policies that if we want to make America healthy again, I'm sorry to use that phrase, if we want, God, that infested my head. If we want to improve public health, the commercial insurance industry is one of the biggest barriers, and it's really hard for me to see the value that they're adding in exchange for killing us.
And I think that is a really perfect segue to like talking a bit about what is the value then that we see in systems like Medicare, Medicaid, and the VA the Veterans Administration, like how those are technically single payer systems. They're not universal, but they're single payer systems. What's the value we see there, and what are some of the, potential like things we can learn from those systems if we wanted to have a more expansive universal single payer system in this country? Oh no, anyone who wants to jump in.
I feel like I've been talking a lot, but I'm glad to hop on. Okay. So the first thing is that the details really, really matter.
Yeah.
So the details really, really matter. So Medicare doesn't cover a lot of things that are really important because in 1965, we didn't know that they were that important and they weren't very expensive. So the details of what you actually cover matter. Your ability to access care really matters. So in some geographies, the VA has tremendously good access, and in some areas it doesn't, because in some areas it's funded adequately to support the veterans that they have, and depending on the severity of the veterans' health status, they can really get access, and in some areas they can't. So the details of how it gets set up really matter, which means we should set up a system that's cohesive and consistent around the country all the same. Your diabetes in Texas is pretty much the same illness as diabetes in Alaska. Not exactly, but almost.
Any other comments on that question?
Yeah. I think Medicaid, I'm really worried about.
I think is it on?
Okay, great. Thank you. I think sorry. Think about Medicaid. We taxpayers pay so much to individuals, but they don't see the money. So what is the incentive there for them to shop cheaper services? There's zero, right? No matter what they do, my problem is that they cannot get any personal financial benefit out of it, no matter how much money we taxpayers pay. Another problem, they cannot go there to see a provider they want. Let's say there's a famous doctor. The doctors just want the money, right? I mean, not all one, but if you pay, they're going to see you, right? But the Medicaid patients cannot see that doctor. Like in Bethesda, where I live, many doctors don't even see Medicare patients, let alone Medicaid. But if the patients have money in their hand, they'll be treated equal. There's no reason a doctor will not see them, right? You pay the money. So that's why I think we have to maintain our subsidization of Medicaid patients, but we have to give them freedom so that they can be untied from right now the very restrictive network and their inability to benefit from lower price or better health.
Thanks. And I do think that the point that you made about restrictive networks is really critical. That's a problem we see in Georgia a lot. And I don't think it gets talked about quite enough when we're talking about the insurance issues, is how restrictive networks are.
And that actually gets back to one response I have to the benefits of a public system. Is it's easier to bargain in bilateral negotiations if you have a government purchaser. And so one of the reasons why we have these narrow networks is precisely because they're bargaining separately. And so they're, positioning their network, other guy as an outside option to the negotiations at hand. And so you get around a lot of these issues when you just have, like a strong negotiating position. So that narrowness of the networks really comes out of as a byproduct of the types of bargaining that can happen at like a public level. So there's that one issue. I'd also say that your point about the incentives that like fragmented insurers have, and I get that. That's definitely one of the issues, that you don't have these long-term incentives. A public insurer also hasn't been great about doing that either. So, even within the systems that we have, with like fee for service, we haven't really developed systems that incentivize like long-term care. But I will say, and I wish there was a political scientist here, like probably much more valuable than economists up here, is thinking about a long-term solution. Is it harder or easier to effectuate like smart changes when we have an idea of, let's say, we need to reduce cost sharing for really high valuable drugs that have no moral hazard aspects like diabetes? Is it easier to do in an environment we have one public payer, or is it easier to promote it through regulations onto private insurers? And what does that lobbying process look like? And so I think we need to think about like the long-term political processes of regulatory changes as new ideas come about. And it's not clear to me whether one system is better than the other. My inclination is probably, single payer offers a lot of advantages there, but I think that political process is really important.
Okay, that sounds, and I think that's getting us towards the end of our questions as well. You actually kind of already started answering the next question I had, which was about Medicare for All, since it's been brought up. As folks in the room probably know, Senator Sanders and Jayapal reintroduced Medicare for All. Companion bills, I believe. But is there a way to eliminate medical debt without something like Medicare for All? We've talked about the public option. We've talked about pricing controls and things like that. What ideas do you all have in that respect about how to eliminate medical debt without something as big and hairy like single payer or Medicare for All?
I think there are other ways, but I think they're bigger and hairier.
Uh-huh.
You could put in so Medicare for All is based on the idea of private delivery but public funding.
Mm-hmm.
Private delivery but public funding. And the simplified funding means that physicians would no longer feel compelled to be employed. They could be out in private practice in small groups and individuals, which is kind of disappearing today. So Medicare for All would preserve the private delivery system and actually enhance the private delivery system, but create public funding of it. How else can you get, but the key is it's first dollar coverage of a comprehensive benefit design for the entire country. So you can do those three characteristics and get rid of the private delivery model and have it be a public delivery model. So you could do a national health service like they do in Great Britain. I'm not a fan of that. That would be less expensive than what we have today, than what Medicare for All would be, but that's culturally inconsistent, and it's not my personal preference, and it's not what our organization. So you could do a national health service rather than national health insurance. That would be
similar to like the VA system,
like a VA system for all. That's bigger and hairier. You could do other intermediate things like an all-payer model, which is kind of emerging, and that would get to some of the value. But if you set up an all-payer with first dollar coverage for comprehensive benefits, that would be too, but it wouldn't capture all of the savings and all of the value. So there's other strategies, but they're not as robust, or they're worse in my mind.
Thanks for that insight. Sara?
So I think it's important. I agree with everything that Ed said. I think it's also important to look at where we are right now. And if let's just say we have the Affordable Care Act. The Affordable Care Act is actually working relatively well in terms of the marketplaces, and Medicaid has issues, obviously, and if we had that framework to work within, there are clear ways of improving benefits that are really driving the problem, aside from the pricing issue. So we could improve the benefits in the marketplaces. It needs serious attention. There have been bills. Senator Shaheen had a bill that we always go back to, that Urban's also done a lot of modeling on, just improving the cost sharing requirements, extending further up the income scale, change the benchmark from silver to gold. Silver plans have really, really high deductibles that people are dealing with. In employer-based area where most people get their coverage. We also need to address the out-of-pocket costs that a lot of people, particularly lower-income people, are dealing with. The problem right now is that we are seeing bills that are actually putting cost sharing into Medicaid, which is extraordinary. We are seeing bills that are actually going to make affordable coverage for the marketplaces less affordable, less people in, probably even drive premiums up, driving people down into even more people choosing for bronze plans just to get. So the policy direction is completely going where it's going to make things worse, and we're just going to see a lot more medical debt. So then you get back to the bigger question is, let's see what the damage is, when the dust settles, and then ask the question, where do we go from here? And I think it is going to be questions about, we have a very fragmented system. It has not worked well at all. And so asking these really big questions about what has worked well, what has not worked well. The Affordable Care Act was never a perfect solution. It was the only solution politically at the time. But we really are going to have to look hard at what we're going to do next.
And I think that is a great point to open it up to the audience, since we have 15 minutes left. So I'll open it up.
I wanted to ask about a workaround that I thought we were going to talk about in this conference, and that is the purchasing of medical debt.
Yes.
A lot of states now legislatures are actually donating money for this purpose. And quite frankly, I question it. But a lot of I'm from the University of Florida, Dr. Fred Southwick, and a lot of medical students are really attracted to this. They're starting to campaign our legislator in Florida to consider paying out medical debt. But it seems to me that's a serious workaround, but I wondered what everybody thought.
I'll just jump in and say that was actually a question we had, but in the interest of time, I decided to forego it. So I'm glad you asked it. Wes?
I would say that there's an asymmetry in forgiveness versus prevention. Okay, so you dig this hole in the ground, and then after the damage has been done, you try to fill the hole later. And I think that that's a really beneficial thing to do. But a lot of damage has already been done already. I think there's a lot of emphasis, and the great folks that undo medical debt would support this, to say that medical debt relief is an important aspect of it, but it really is a tail end solution to a problem that we need to solve upstream. And so there's a lot of damage that will happen. And so how about this? Why don't we relieve medical debt instead of 5 years after the debt? How about 2 years? Oh, how about 1 year? How about at the point of service? Oh, then we're talking about insurance. So that's the reason. And I think one of the reasons why we have a lot of debt forgiveness is really because, the folks are using ARP money on this. They see the 100-to-1 leverage and say that we're getting rid of a lot of debt. And that really resonates with people. And I think that's an important thing. It resonates with people in the same way that there's a lot of energy in this room. It resonates with people because we just think it's unfair. Well, okay, why don't we take that energy and apply it to the prevention side? And I think that's where we need to focus our attention.
Yeah, actually, so since our last panel, I'd love to get to people who haven't had a chance to ask a question yet. So if you haven't gotten to ask a question yet, well, I'll go to you first, but then if you have, I'll go to you second. Yeah, great.
Okay, so since I'm the organization that does do the tail end work and is getting all those government funds, I just want to say I completely agree, and I think everyone knows that we do not think that we are the solution by any stretch to this problem. But I think our work is bringing a lot of air to this conversation, which is really important. What I'd like to ask, though, also is is there a combination? I really am here today because I'm extremely frustrated, like everybody else. I'm worried about the current situation. What's the political angle here? What is the Republican side of things thinking since they're in charge right now? And what are I can't help it. I'm an optimist, and I'm okay. the world feels like it's on fire and it's blowing up, but like maybe that's an opportunity. Maybe because, and I think you said this a little bit, like that, like there's opportunities, there's changes. We can see how the dust settles and then move on. But what is that moving on? Like what, like, is there a, you know, talking about public-private option, like, is there a public option that sort of run by the government? I'm making this up, but that employers can buy into, so it's cheaper than the private. You know, has that been talked about? Those are the kinds of things I'd like to hear.
Yeah, there's a lot of versions of this, and I mean, I think I just alluded to them earlier on, which is you could, on the pricing side at least, you can think of just public procurement. You can also think of having private plans be given publicly negotiated rates, so the government is setting the rates. That could be voluntary participation by hospitals, in which case it's considered, quote unquote, a weak public option, or they have to eat it. They have to take it. And that's a stronger one, which is essentially rate negotiations and rate setting. And that's still a softer version of just setting rates, because what we're doing is we're having a public option go into a market, and then that's providing discipline to the private insurers and whatever, and so on and so forth. And that's kind of a lighter version of that. We could also have a situation where, let's say we have a government option, we have a government-run PBM, and then employers can hop onto it. There's a lot of different things that we can think about. I put it all under the class of rate regulations. It's just different ways of doing that. Yeah. Yeah, I mean, I think you'd have to talk to someone out of the caucus there. I mean, there's folks here in Leg Affairs that know a lot more about this than I do, but you know, I see there's a tension on the Tea Party populist side, and then you have a corporatist side, and I think they're at odds right now, and there's a lot of opportunities for odd bedfellows at this point. But I'd leave it to the Leg Affair folks to talk about that.
I think that's true. I think the odds that we're going to get a public option or Medicare for all in the next 4-6 years is pretty low. But I want to say two things. First, you know, a thought about the public option strategically, and then sort of a description of what a good public option would be. Strategically, the reason I'm not eager to see us chase a public option, it'll take 4 to 6 years to pass one. It'll take another 2 to 5 years to implement it. And then it'll take another 3 to 5 years to assess the value. So 10, 12, I don't know, years from now, we would then be looking at a program that's we're never going to get us to where we really want to get. And then we'd be back, like Winston Churchill said, doing the last right thing. Mm-hmm. So, but if we did want to go down, if there are three key characteristics of a good public option, the first, I think, is that it has to be tied to Medicare, to regular Medicare, not to Medicare Advantage, but to Medicare. And that means use Medicare rates. That means a physician or hospital would have to accept the public option and traditional Medicare, or accept neither. So then you would have the full network of traditional Medicare. So the first key is it's got to be strongly tied to Medicare, not to Medicaid. Medicaid, then you would have it varying from state to state. Mm-hmm. And the states that most need the value would be the states that would be the last ones to adopt it. I live in Missouri. Trust me, that's really true.
Georgia.
The second piece, it has to be better than Medicare. So a good public option would have 0 copays, 0 deductibles. It would have comprehensive benefits, you know, hearing, vision, dental, nursing care, all of that stuff. And then the third piece, which is probably the most important, is it would have to have a strategy to mitigate adverse risk. And the way you can do that, I think, is to design it so that it would start large and continue to grow. So starting large means let anybody who wants to be in it. Let any individual, be they insured today or not insured today, let them opt into it. Let an employer decide to shift their whole book of business from commercial insurance into this, and then they can stop negotiating all this nonsense. Let states shift their Medicaid business into it if they want to. So the benefit design would have to be as robust as Medicaid's is. So let a state shift in. But then probably the most important and most difficult piece is it would have to auto-enroll all of the uninsured today. Oh my God, a mandate. But make it really easy for anybody who's auto-enrolled to opt out. And then you have the behavioral economics principle that people of inertia. So people, if you make it opt in, you get 10%, 15% of the uninsured. If you make it opt out, you would retain 85 to 90% of the people. And if you did those things, it would be large enough to mitigate the adverse risk. So it's got to be tied to Medicare, not Medicare Advantage, not Medicaid. It's got to be better than Medicare, and it's got to be large and able to keep growing.
Mm-hmm. That's a great point. If assume for a second we are the hospital CEO, what would you do? If I am the CEO, I would not sell my debt to you because you're a private buyer. I'm going to work with my regulator in my state to ask taxpayer money to buy. Why? It's much easier to work through, right? They will not pay market rate. They will pay much higher than what I could have collected if I go through the process. By this way, I will get more money from the government, right? From taxpayers. But at the same time, patients understand if I don't pay, government is going to pay. So the collection rate will drop. But that's amazing for me because why? I will ask taxpayers to keep funding me. Then eventually we'll in effect go into a single payer system.
Perfect.
And then, yeah, I would say that's probably what a CEO want to do. You might say, this rate might be too low if we go single payer. I don't think so. I believe right now the price setting process extremely captured by hospitals. That's why we're seeing hospital price. If you look at the trend, right, very, very high and rapidly increasing because they really are very, very powerful capturing the process. So they would love to, I'm talking about powerful hospitals. They would love to have government pay off the debt and then influence the pricing process. So that just from a purely, self-interested CEO's perspective.
Oh, Sarah, go ahead.
Just so one thing obviously that's got to determine what happens is these are always political political decisions and political environment. And the Affordable Care Act, if you remember, there was we got to a point where there was just momentum and it was in all the candidates' health plans in a couple of election cycles for finally So we are doing focus groups right now with people with medical debt, people with collection, people who have claims denials, and then and billing mistakes. And so we're asking them, well, what do you think the government should do? What do you think should be done about this problem? And a lot of people are saying, I think we should think about other countries. I think we should have systems maybe like, and these are not informed. These are people who are not informed about health policy the way we all are, obviously. And thinking that way, that something big needs to be done because this is intolerable and it's not fair. I pay my premium and yet I'm having all these problems. These are people with employer-based coverage. So is it, and the medical debt has been catalyzing, I think, on both sides. Are we at a place, and what we saw in December and January about the with United Healthcare, are we at a moment where the frustration is so high that people are open to thinking a little bit differently about our system?
Christine has a question here. As you're walking over, I would just like to say that I want everyone to take a look at an article in the New York Times called "Why Doesn't the United States Have Universal Care? The Answer Has Everything to Do with Race." Please Google that article because I think it is extremely important that we haven't really addressed race in this conversation today, because it really is at the heart of why we have these problems, and particularly anti-Blackness. I just want to make sure I uplift that. But it's called "Why Doesn't the United States Have Universal Health Care? The Answer Has Everything to Do with Race." New York Times. Christine.
Yeah, it'd be great if you could email that. Or if there's like a sharing of resources after the conference, I'd love to.
I'll send it to Vikas.
Thank you. What I wanted to mention about the politics of this issue, kind of a good news, bad news, not to be Pollyanna-ish, but if you think about the CFPB rules, the Consumer Financial Protection rules that were, overturned by Congress recently, medical debt, the wonderful CFPB rule to take medical debt completely off credit reports, that has not, even though it's been introduced, that has not, been up for a vote at all. And I think that's very telling because no politician wants to tell their constituents, hey, I'm voting against this proposal that would take medical debts off your credit reports. And I think when you think about the Republican frame of mind or viewpoint of life, I don't want to generalize. I'm not a Republican, but what I've observed is like, unless someone has felt that harm personally, that harm may not be real for them. And, hearing a lot of your stories, there's obviously medical debt is something that we're all very familiar with. So I think I wanted to just say thank you. Like so many of you in this room have done really great work to get the stories out there. And I think that's ultimately going to be what moves the needle and what has moved the needle. Michelle's group, Community Catalyst, there's been a lot of stories out there. NCLC has pushed out stories that make this issue very relatable. Now, here's the warning part. When those stories aren't being pushed out there, I think, and we're not really paying careful attention to the process, that's where the danger lies. So right now, in the House version of the reconciliation bill, there is a provision in there that would preempt all state cases having to do with AI. So I've heard like 3 of you in the room today talk about the dangers of AI, especially as private equity is taking over so much of the healthcare space and they're trying to save money using AI. What does that mean, especially for communities of color? How are they going to be shortchanged? How are consumer rights going to be put at risk because AI is now being used to determine who gets care or how it's administered? And there is a provision in the House reconciliation bill that hopefully will not go through the Senate version, hopefully would get killed by the parliamentarian, but it would essentially for 10 years not allow any kind of state, state causes of action that have to do with AI, and would preempt all those state cases. So again, preemption is, I think, another part of the problem as well.
And it looks like we have 50 seconds left, so we have a little bit of time. And it looks like Elizabeth maybe has a question.
Sorry. One of the things that I keep thinking would be an interim path, and I guess this is for Sara or maybe I don't know, Wes, Ed, I don't think I probably know your answer, is that, it seems to me that like one of the interim things that the United States could consider if we weren't able to do Medicare for all would be something like the Switzerland model, which is we would use private insurance with provider rate setting, because I really believe Yui Reinhardt was right with it's the price is stupid. And so it seems to me that would be a really interesting approach that possibly we could get some bipartisan, so I'm just curious if what you all think about that, or is that just delusional hopefulness on my part?
It is probably the closest to our system, and in fact, it's basically nonprofit insurers on exchanges. So it's a model that I think people, because of the Affordable Care Act and all the people that have coverage through the marketplaces now, seems less foreign to them. So in that sense, and there is cost sharing, but it's capped, and there's nowhere near as high as what we have right now. So I that to me seems like right, exactly. Yep.
At least the reference, at least the reference basis.
Yeah, that's right.
Yeah.
Well, I think that is our time. Hopefully we rocked it on this last session. I would like to thank all of our lovely panelists for this very robust conversation. Sara, G, Ed, and Wes, thank you so much. Thank you.